Asthma Case Study by Georgina Calderon. Asthma is a chronic, reversible, inflammatory disease of the airways. Asthma is characterized by recurrent episodes of wheezing, shortness of breath, and chest tightening, and coughing. Asthma reaction is developed due to an allergic inflammation response caused from an interaction between the respiratory epithelium and leukocytes that respond as part of the immune system. Stimuli, which can be of genetic or environmental nature, provoke the release of mediators that initiate the inflammatory response in the epithelium, resulting in inflammation, bronchospasms, epithelial damage, mucus production, and airway remodeling. This image provides a visual illustration of the effect asthma has on the bronchial tubes. Things that can trigger an asthma reaction include animals, dust, mold, pollen, chemicals in the air or in food, exercise, respiratory infection, smoking, or secondhand tobacco smoke. Asthma diagnostic testing can be done with the spirometer, which estimates the narrowing of the bronchial tubes by checking how much air you can exhale after a deep breath and how fast you can breathe out. A peak flow meter is a device that measures how hard you can breathe out. Low peak flow readings are a sign that lungs may not be working well. Methylcholine challenge is done with methylcholine, which is a known asthma trigger that when inhaled will cause a mild constriction of the airways as an indication of asthma. A chest x-ray and a CT scan of the lungs and sinuses can identify any structural abnormalities or disease. Allergy testing can identify allergy triggers and can lead to a recommendation for allergen immunotherapy. In 2007, the National Asthma Education and Prevention Program released the Expert Panel Report 3 with guidelines to the stepwise approach as recommendation for asthma treatment and management. The stepwise approach is to be used as a guide for increasing the treatment. It is important to confirm symptoms are due to asthma, check adherence and inhaler technique before considering stepping up treatment. This report also provided guidelines for collecting asthma history, which include symptoms. Symptoms can include cough, wheezing, shortness of breath, chest tightness, or sputum production. Pattern of symptoms. Are your symptoms annual, seasonal? Are they continual or episodic? When is the onset of your asthma, and how is the duration and frequency of your asthma? Is your asthma during the daytime or nighttime or both? Aggravating factors. Viral, respiratory infection, environmental allergens, smoking, exercise, and comorbid conditions such as GERD can all be aggravating factors. Family history. A history of asthma, allergy, sinusitis, rhinitis, or eczema in your family can indicate a higher asthma probability. Social history. Daycare, workplace, and social factors that may interfere with adherence. Social factors that can interfere with adherence, such as substance abuse. Social support. Asthma is a life-changing condition. Social support is important. Development of disease and at what age was the diagnosis developed? The progression of the disease, frequency of short-acting beta-2 agonist use, and frequency of corticosteroids use. Differential diagnosis for asthma can include pulmonary emboli, chronic obstruction pulmonary disease, chronic heart failure, pneumonia, viral infection, and foreign body aspiration. Let's move on to our case study. Alex is a 19-year-old Caucasian male who presents to urgent care with complaint of asthma exacerbation. Patient states he has symptoms consisting of cough, wheezing, shortness of breath, tightness, and moderate sputum production for the past 24 hours. In addition, the patient reports he has had an upper respiratory infection for the last 2 days and has increased the use of his albuterol inhaler. He states he has administered albuterol treatments every 3 hours without significant relief of symptoms. His medical history includes asthma, diagnosis onset at 9 years of age. There is no past hospitalization. Medications include controller inhaler, Pulmicort, 180 micrograms, 1 puff, twice a day. His albuterol inhaler, 2.5 milligrams, 4 to 8 hours as needed. He has an allergy to penicillin and seasonal allergies. His social history, he denies tobacco, alcohol, and illicit drug use. He states he attends gym 3 to 4 times a week. He has an office-type employment and lives with his parents. There are no smokers in the household. His family history includes his mother, hypertension, hyperlipidemia, and hay fever. His father is positive for diabetes and hyperlipidemia. During assessment, you notice the patient is anxious yet alert. He's sitting on the edge of the examination table, leaning a bit forward. Mild intercostal retractions are noted. When the patient is asked if he can tell you his name and recent activities, he must stop and take a breath after 5 words. However, he is able to fully communicate his response. His weight is 73 kilos. His height is 6 feet 2 inches. His heart rate is 139. His respiratory rate is 38. His O2 saturation is 91% on room air, and his blood pressure is 124/78. He's afebrile with 98.9. Patient states he usually experiences asthma symptoms less than 3 times a month, and rare symptomatic nighttime awakenings less than 2 times every 2 months. The last exacerbation he had was about 2 years ago. According to the guidelines provided by the National Institute of Health, Alex's asthma is generally well controlled. During your review of symptoms, Alex's constitutional state is negative for fever, chills, and fatigue. He denies headaches or dizziness. His ears are negative for tinnitus, earaches, or discharge. His nose is negative for congestion, discharge, itching, or nosebleeds. His throat is positive for mild sore throat and negative for dry mouth or hoarseness. His neck is negative for lumps, swollen glands, goiter, pain, or neck stiffness. His respiratory is positive for shortness of breath, wheeze, cough, with moderate sputum production, but negative for hemoptysis. His cardiac is positive for chest tightness and negative for chest pain, palpitation, swelling of the ankles, or chest pain with exertion. Allergy-wise, he's positive for seasonal allergies, but negative for hay fever or runny nose. His skin is negative for rash, hives, redness, lumps, or lesions. During your examination, Alex's general appearance is anxious. However, he is alert and cooperative and well-groomed. Examination of the ears show his external auditory canals and tympanic membranes are clear. His hearing is grossly intact. His nose presents with non-inflamed mucosa. The septum and turbinates are normal, without discharge. Examination of his throat shows minimal erythema of the oral cavity and pharynx. The mucous membranes are negative for inflammation, swelling, exudate, or lesions. His neck is subtle, non-tender, without lymphadenopathy, masses, or thyromegaly. During cardiac auscultation, you hear normal S1 and S2 heart sounds. No S3, S4, or murmurs are heard. His rhythm is tachycardic. He is negative for cyanosis, and his extremities are well perfused and warm to touch. His capillary refill is less than 2 seconds. Lung auscultation presents with increased expiratory wheezing throughout all lung fields. Fine crackles to bilateral lung bases are heard. No bronchi or diminished breath sounds are present. The pre-bronchodilator spirometer results are FEV1 at 65%. According to the history gathered from the patient and the National Institute of Health guidelines, the patient is having a moderate asthma exacerbation. The dyspnea caused by the asthma is interfering with Alex's usual activities. His pre-bronchodilator forced expiratory volume is 65%, which falls in the NIH classification for moderate exacerbation. And although he had a difficult time answering questions, he was able to communicate effectively. The immediate goal for treatment is to decrease the inflammation to the bronchial tubes. Therefore, Alex will be treated with albuterol via small volume nebulizer. 5 milligrams every 20 minutes times 3 doses will be given. This will be followed by 10 milligrams of albuterol via small nebulizer after 1 hour. During reassessment, Alex appears to have responded well to the therapy. His vital signs at this time are blood pressure 118/72, his heart rate is 114, his respiratory rate is 25, and his O2 saturation is 95%. Keep in mind, tachycardia and shakiness are to be expected with the multiple doses of bronchodilators. His spirometer pre-bronchodilator is 65%, and post-bronchodilator is increased to 85%. His forced expiratory volume has increased by more than 20% and more than 200 mL from baseline, suggesting significant bronchodilator reversibility. The patient will be started on oral steroids. A Medropac will be prescribed. During long auscultation, we heard fine crackles to bilateral lung bases. Therefore, a chest X-ray might be useful to evaluate upper respiratory infection disease process in his lung. For better asthma control, have Alex complete a written action plan. This will help manage his asthma on a daily basis and help him deal with future exacerbations. Before sending the patient home, patient and family education will be given. This will include the goals of prevention, which are to eliminate triggers and to keep on your action plan. Eliminate tobacco smoke if any. Smoking outside the house will not help since smoke residue comes in the house on clothes. Avoid pets, keep them outside the house. Vacuum and dust regularly. Wash clothes, bedding, and stuffed toys in hot water. The stuffed toys that cannot be washed, freeze them for 24 hours. Teach proper inhaler technique. Suggest a spacer use for best medication delivery. Follow-up instructions need to include a follow-up visit with his primary care physician, which should be scheduled for 1 to 2 weeks from now. In addition, a follow-up visit with his pulmonologist should be scheduled for 2 weeks from now. This concludes our asthma case study presentation. Thank you for taking the time to listen.